Good evening, one and all. On behalf of Yashoda Group of Hospital, we welcome you to again a series of webinars conducted by Department of Emergency Medicine and Critical Care in collaboration with. Today we have an interesting topic. Any female come to emergency room, so come with pain abdomen or any other thing, just how to approach and then how to evaluate, how to put the diagnosis, and then how to manage effectively. That we are going to have an excellent speakers today. Today, I welcome Dr. Sharda ma'am. She's a consultant and senior gynecology and obstetrician at Yashoda Hospital, Somajiguda, as well high energetic emergency physician, Dr. Sama Hussain. She's going to talk on the ED management. So at the end, we would like to take questions. So I would like to ask Sharda ma'am to begin with. Uh, this topic is overview of gynecological emergencies as well how we manage in ED. Yeah, over to the floor. Yes.
Thank you, Dr. Suresh. That was such a nice introduction. And I thank Dr. Suresh for coming up with this idea, because gynecological emergencies might be the last thing which an emergency physician would ever want to read. I don't know, somehow, but still this is a nice opportunity for me to discuss some gynecological emergencies. So next, Sama. So we thought we'll just broadly discuss about your common things. Most of you must be coming across this ectopic pregnancy, twisted ovarian cyst, dysmenorrhea, menorrhagia, acute pain abdomen. So we get reference for all these things. So we'll discuss in detail about these things. So our first case, Miss A, 28 years, she comes to ER with a complaint of severe pain abdomen. So what is the first question in the history which you would like to ask? So we thought we'll have a question answer session, but then because it's a virtual background, virtual platform, we cannot have it. So definitely the answer would be her last menstrual period, when her last menstrual period was. So when we asked her, she says it's 5 weeks ago. Once we get this history, the first diagnosis which comes to us is definitely an ectopic pregnancy. So pain abdomen and missed period, the first thing goes is ectopic pregnancy or an early pregnancy complication. Then we have to confirm. So what is your simple test? Of course, a urine pregnancy test. Now she's asked to collect the urine for test, and she goes to the washroom, because most of the times they walk to the washroom and she collapses in the washroom. That is a common scenario in ERs. So now I request Dr. Sama to discuss emergency management of ectopic pregnancies. Dr. Sama.
Thank you, ma'am. Yes, ectopic, like you said, ma'am, gynec emergencies is something that I've always personally been scared of. Every time I get a gynec case, the first thing I try to do is involve the gynecologist as a resident. But over the years, we've learned to manage a few of the conditions. Ectopic pregnancy, ma'am. So what I'd like to talk about ectopic pregnancy first. What is ectopic pregnancy? Any gestational sac implantation which is outside the uterus is called an ectopic pregnancy. So what happens is, it is very essential to diagnose this in the ER, because the patient will come with simple complaints like pain abdomen or mild vaginal bleed, which can be mistaken as for dysmenorrhea. Pain abdomen, vaginal bleed can be mistaken as dysmenorrhea. But when this is combined, with a symptom of one episode of syncope, it is very important to keep a high suspicion to make sure, you suspect ectopic pregnancy. That's the best way. First thing to diagnose. The best way to diagnose ectopic pregnancy is to have high suspicion. Any case that you get, any patient in a reproductive age, any female patient, reproductive age, with pain abdomen, vaginal bleed, with syncope, should give you a diagnosis of ectopic pregnancy. How do we diagnose it? One is high suspicion. Unless you can't diagnose something that you don't suspect. So any case you suspect an ectopic pregnancy. When you suspect, you get a urine or blood HCG levels, beta HCG levels. Urine pregnancy test, when you get that, the simplest bedside test we can do in the ER, you get the results in about 2 to 3 minutes. That's all. If that's positive, then it's a high chance that it's an ectopic pregnancy. Pain abdomen with a positive pregnancy test, ectopic pregnancy is a really high chance. So we always have to be cautious. Make sure you're asking for the LMP. Make sure that you're getting the urine pregnancy test, even if sometimes we get a lot of patients who are very reluctant to get a pregnancy test. As an ER physician, it's important that we communicate properly with them and build our confidence and rapport with the patient and convince them for the test, because that could be life-saving. Once you have a positive ectopic pregnancy test, you can either do a fast in the ER if the patient is unstable, or you can send the patient for a transabdominal ultrasound. The gold standard diagnostic test to diagnose an ectopic is a transvaginal sonography scan. But a lot of times we do a simple transabdominal scan also helps diagnose it. So these are few images where you can see the free fluid in the abdomen, which is seen due to a ruptured ectopic pregnancy. How do we manage? ER management is very simple. We always follow the ABCDE approach, irrespective of what's happening. If your patient is unstable, we always start by securing the airway. Secure the airway, secure the ventilation, move on to circulation. A patient who has a ruptured ectopic will most probably be in shock. So you have to insert 2 large bore IV cannulas, collect the labs, send a complete blood picture, send your serum HCG levels, cross-match for blood, because if the patient needs surgery, you will require blood later. And in these cases, it is essential to request for an RH and antibody status, RH antibody status, because anti-D Ig immunoglobulins may be needed. We resuscitate enough with IV fluids, which is essential to stabilize the patient and bring the patient out of the shock. Early gynac referral involve the gynecologist quickly, because the patient may require surgery. And once the gynac team is informed, it is essential that every person in the ER moves in a synchronized manner. So inform the gynecologist team, inform the anesthetist, keep the anesthetist in loop, keep the OT team in loop, so that if any significant hemorrhage is suspected, we can shift the patient quickly to the OT. A lot of times, yes, OT may not be required, but I'd like ma'am to continue on that and give us the definitive management for ectopic pregnancy.
Thank you, Sama. So as you have already told, we all know ectopic pregnancy is a pregnancy which is not implanted in the uterus. Most commonly, it is ampullary pregnancy. Ampullary pregnancy is in the ampullary part of the tube. Next, it is the isthmic part. Then comes the fimbrial and cornuolens. So apart from tubal pregnancy, we also have ovarian pregnancies, cervical pregnancies, cesarean scar pregnancies, and abdominal pregnancies. Next slide. So we have an incidence throughout the world of about 2%. So 2% of all pregnancies in the world is ectopic pregnancy, and it accounts for 3.5 to 7.5% of maternal deaths in India. So we have some risk factors. Next slide. So how do we diagnose? As Sama has already told, we have some guidelines, and as per our society guidelines, transvaginal ultrasound is the diagnostic tool of choice for tubal ectopic pregnancy. So many a times we come across in ER that we get confused, and all pain abdomen patients are shifted for an CT, which is a much better, probably in ER to get a CT done than an ultrasound. So, but the guidelines say it is the ultrasound which is the diagnostic tool of choice for tubal ectopic pregnancies, and clinicians should be aware that ultrasound is the primary diagnostic modality, supplemented by transabdominal scan. Next slide. So these are some of the images. So we can see a ring of fire appearance in the adnexa, which suggests an ectopic pregnancy. And in the second picture, you can see fluid in the pouch of Douglas and an empty uterus, so which suggests an ruptured ectopic pregnancy with hemoperitoneum in the pouch of Douglas. So it is important to emphasize, however, that a female patient with pelvic pain should always initially be imaged with ultrasound, particularly if there is a possibility of ectopic pregnancy. CT is certainly not an appropriate modality to be used for the purpose of diagnosis. So whenever a CT is supposed to be done, a strict urine or serum beta HCG screening should be done before a CT is done. So but still sometimes we do miss the screening criteria and a CT or MR comes up with ectopic pregnancy. Then the features are a hematosalpinx and a hemorrhagic or heterogeneous mass, bloody ascites and tubal dilatation, fallopian tube dilatation with wall enhancement. So most specific finding of ectopic pregnancy is, however, an identification of extrauterine gestation sac, which is typically seen as a cystic sac-like structure surrounded by a thick wall corresponding to the tubal ring sign seen on sonography. Next slide. So this is one of the CT image where you can see adnexal cyst, you can see a big arrow showing an adnexal cyst with a fluid in between as well as hemoperitoneum around the paracolic gutters. So how do we manage? So yes, management is definitely by involving the gynec team, but sometimes you may be sitting with the gynecologist for counseling session. So you everybody should know what the guidelines say. So the guidelines say that a laparoscopic approach is preferable to an open approach. In presence of a healthy contralateral tube, salpingectomy should be performed in preference to salpingotomy. So many a times the patients, attenders get so panicky, they want the fallopian tube because of future fertility concerns, and they go on ask the same things. So can you preserve the tube? Why can't the tube be preserved? Or you bring the pregnancy from the tube into the uterus. So these are the common questions which we get when we counsel ectopic pregnancies. So we have to stick to these guidelines and explain them, that the science or the evidence tells us that in presence of healthy contralateral tube, the other tube is healthy, salpingectomy, the removing the unhealthy tube, is preferred to salpingotomy, that is opening up of the tube. But in women who have a history of fertility reducing factors, like a previous ectopic pregnancy, or if the other tube is damaged, then salpingotomy, she has got only one tube, and even in that the ectopic has come, then you have to think of salpingotomy, that is opening the tube and just removing the pregnancy. Next slide. And if salpingotomy is performed, we have to tell them that there is a risk of persistent trophoblastic tissue and a serum beta HCG follow-up should be there. Next slide. So we can also give them systemic methotrexate expectant management, which are not concerned with the emergency managements. They are an outpatient-based managements for ectopic pregnancy. Next slide. So this is second scenario. It's a young girl, 12 years, brought to ER with a complaint of severe pain abdomen since morning. So 12 years, young adolescent girls come to ER with nausea, vomiting. First thing, a GI consult will be done and supportive medications for nausea, vomiting, pain are given. She gets an instant pain relief and goes home. But now she comes back again the next day with pain abdomen. And now, because second time she has come, we do an ultrasound. A 4 centimeter simple ovarian cyst is diagnosed. But the patients are highly fussy, especially the mother. She says it's all normal, 4 centimeters should be normal in that age and all. Now a urology consult is taken because why the pain and all. Now again the supportive pain medication is given. They leave ER. Now she comes back at midnight with severe pain. Now a CT shows an enlarged ovary of 8 centimeters. So now we get the diagnosis. Now diagnosis is changed to Dr. Sama, will you take over to discuss the twisted ovarian cyst?
Yes, ma'am. Now, when you see that, though, she's come back to us with a CT scan, which is showing that enlarged ovary of 8 centimeters, twisted ovarian cyst. Twisted ovarian cyst or ovarian torsion. It is quite difficult to diagnose this in the ER because you get the patient presents with sudden onset of sharp unilateral pain, which can be, mistaken for a lot of surgical causes. We have a lot of surgical conditions which come with this similar history, be it appendicitis or renal calculi. So it is very essential that, again, we keep these diagnoses in mind when we are seeing any patient, any female patient. It is always important to keep the gynecological diagnosis also in mind. Patient presenting with sharp abdominal pain and sharp unilateral pain, sudden onset, you should also have your diagnosis of ovarian torsion in mind. The best way of diagnosing an ovarian torsion is how you diagnose any vascular abnormality. When there's a vascular abnormality, the pain will be disproportionate to the symptoms, to the other symptoms. She'll be in severe pain, which will not respond to a lot of analgesics. So then you should always think that is there some vascularity involved? Is ovarian torsion an option? So on clinical examination, there will be tenderness per abdomen and there will be tenderness on per vaginal examination. The best way to diagnose this is to get a transvaginal ultrasound with Doppler. Again, something that we don't do very often in the ER. We generally go and get a normal transabdominal ultrasound. But it is, if there is suspicion in the transabdominal ultrasound, if it's seemingly normal, you don't find any other cause, then also an ovarian torsion can be an option. That you should always keep that in mind. And involve the gynecologist, ask, we should get a transvaginal ultrasonography with Doppler done. Always start the patient on analgesic. Any patient coming to your ER, and in this current age of time, if the patient is still in pain after coming to the ER, it is not acceptable. When we have so many ways to reduce the pain should always be managed well. Definitive management is generally laparoscopy, but Dr. Sharda will be able, Sharda ma'am will be able to tell you more in detail about that. Other causes is hemorrhagic ovarian cyst. Hemorrhagic ovarian cyst can present in shock too. So it is important to resuscitate the patient well, stabilize the patient, and inform the gynecological team as soon as possible. Keep them in the loop. It is important to keep these diagnoses in your mind when you're looking at any female patient, because we generally tend to look at all the surgical causes, but and seem to miss out on some of the gynecological causes. So any female patient, keep your eyes open, look for signs of ovarian torsion. This has a window period, so if the surgery is done quickly, we can salvage the ovary. So I'll send it over to ma'am so that she can continue with the management.
Yes, Amma. So ovarian torsion is definitely a difficult diagnosis to make, especially in this age groups, adolescents and what. So ovarian torsion can occur at any age. So especially in adolescents, we don't think of these things. So ovarian torsion is twisting of the ovary and a fallopian tube on its vascular and ligamentous supports, blocking adequate blood flow to the ovary. So the thing here is the blood flow is blocked. And how is it? It's frequently described as unilateral ovarian on an ultrasound. Ultrasound is the diagnosis of choice. So it's a unilateral ovarian enlargement and edema with peripherally arranged follicles. So this sign is more common in prepubescent ovaries. Affected ovary may appear like a solid mass with hypo and hyperechoic areas in keeping with hemorrhage and necrosis. So the twisted pedicle is seen as a whirlpool. So whirlpool sign is very typical of a twisted ovarian cyst. And grayscale on color Doppler, the Dopplers increase the diagnostic sensitivity for torsion. These are some of the images. The right side of the image shows some vascularity in the ovary. The left side, there's no vascularity and the ovary is enlarged with peripherally arranged follicles, which suggests an ovarian torsion. CT and MR, these also are useful in the diagnosis of torsion, and the same findings which are showing in an ultrasound. So enlargement of the ovarian stroma, tube thickening, ascites, uterus deviated to the affected side, all these are show findings we see on a CT. Next slide. So this is okay. So
sorry.
Yeah. So that's the adnexal mass on a CT scan. And you can see so the laparoscopic, okay, Sama. Laparoscopic detorsion is the management of choice. So we all know that the laparoscopic detorsion will definitely save. So the blood supply to the ovary is stopped because of the torsion. So detorsion definitely makes the ovary viable. And we have to save time on this. So likelihood of preserving viable ovarian tissue with conservative surgery decreases over time, with some evidence that pain for longer than 48 hours. So we miss in ER once, twice is fine, but within 48 hours, we have to catch this twisted ovarian cyst. That will significantly, so if we cross 48 hours, that becomes necrotic and we cannot keep the ovary viable. So we have to pick this up before it is in the pre-viable stages. Yes. So as Sama has already told, we have other cyst complications which can come like cyst hemorrhage. So they come with sudden pain and you do an ultrasound, you find a big hemorrhagic cyst. So hemorrhage might have just happened into the cyst and they can come with severe pain. Or a cyst might rupture and there can be hemoperitoneum or the torsion is the one which we have already discussed. So this is another case scenario. ER coming with severe pain in the lower abdomen on the first day of the period. So maybe once in week you get this type of patients. So dysmenorrhea is a common thing in all age groups, not just young girls or middle age. So in all age groups, dysmenorrhea is very common. Now, what would you do, Dr. Sama?
So in any dysmenorrhea case you get, it is always essential to rule out an ectopic or threatened miscarriage, because it could be the first trimester, it could be, in the first couple of weeks of the pregnancy where even the patient doesn't know that she's pregnant. So it is always essential to rule out an ectopic or a threatened miscarriage. A simple bedside urine pregnancy test will clear that out for us. Dysmenorrhea is caused by increase in prostaglandin release. So NSAID is the best option. NSAIDs are the best option to relieve pain in abdomen in dysmenorrhea cases. What are the causes of dysmenorrhea? There are multiple reasons. It is important as ER physicians that we understand when that the pain during different parts of the cycle. We can have patient can suffer with pain. So it is essential to differentiate between the different kinds of pain, different causes of pain. Endometriosis, you'll have dysmenorrhea, which can cause problems like infertility, dyspareunia. Endometrial cyst might rupture and bleed severely into the pelvis. In this case, the patient may may present in shock, may present with history of syncope, and the rupture can bleed severely into the pelvis. A simple fast scan will show you free fluid in the abdomen, and this can require a diagnostic laparoscopy also. Endometrial cyst rupture is very important, as the patient will present with severe pain and the patient will be bleeding severely. Patient can go into shock. So it is essential that we manage and always keep our ABCDE in mind, manage the patient appropriately, involve the gynecologist, get a transvaginal ultrasonography, and move a patient with a diagnostic laparoscopy. Now, if the pain occurs mid-cycle, that can also be pretty painful. A rupture of corpus luteal cyst can cause significant pain and bleeding, hemorrhage, which can leave the patient shocked. And it is important to realize what's happening, to understand that, the patient is mid-cycle. So any female patient, irrespective of when her what phase of her cycle is presented to you, it is very essential that you ask the LMP and correlate her symptoms with the LMP, because that will give you an appropriate diagnosis. Ma'am?
Yes, Sama. So as Dr. Sama has already told you, keep the ectopic pregnancy in your mind. So even if she's having her periods, you should first think of ectopic. So pain, and a young girl or reproductive age women, think of ectopic, do a urine pregnancy test. Dysmenorrhea, coming back to dysmenorrhea, as Dr. Sama has told, is a painful cramps that occur with menstruation. It's a most common gynecologic problem in women of all ages and races. The characteristic symptoms are lower abdomen or pelvic pain with or without radiation to back or legs. So that's what they present with. And initial onset 6 to 12 months after menarche. And that is a primary dysmenorrhea. And pain typically lasts for 8 to 72 hours. So most of them, they say we have first 8 hours pain is there, or pain might persist for 3 days. And usually occurs with the onset of menstrual flow. And there might be other associated symptoms like low back pain, headache, diarrhea, fatigue, nausea, vomiting. So Dr. Sama has already told us about this primary and secondary dysmenorrhea causes. Next slide. So how do we treat? Yes, dysmenorrhea is because of imbalance of excess prostaglandins in the uterus. So a Cochrane review has said that non-steroidal anti-inflammatory drugs are the first line treatment of primary dysmenorrhea. So as I understand, you all have pain analgesia protocols to be given, but for dysmenorrhea, non-steroidal anti-inflammatory drugs are the treatment of choice. Next slide. So ACOG recommends that COX-2 inhibitor celecoxib is the initial management. 40 milligrams initially, then 200 milligrams every 12 hours. Ibuprofen is another drug of choice, 200 to 600 milligrams every 6 hours. Mefenamic acid, so we all give mefenamic acid, but dose is 500 milligrams initially. So give a double dose of it and then make it 250 milligrams every 6 hours. Naproxen also can be used 450 to 550 milligrams initially, then switch down to 220 to 275 milligrams every 12 hours. So we thought we'll also discuss heavy bleeding. So most of the times it happens that women come with heavy bleeding since 5 days, since 2 weeks, since some months. So they come with heavy bleeding, whatever be the age group. What is your emergency management? Dr. Sama?
Heavy bleeding, we do have a lot of patients in different age group who've come with uncontrollable bleeding. Sometimes they're bleeding for a couple of days. In that, it is important that we categorize them properly, whether the bleeding is mild, moderate, severe. It is important to get a thorough gynecological history as to how many days is she bleeding for, how many pads is she changing per day, and how heavy the bleeding is. So that gives us an idea on how we can categorize it. But to categorize it, it is important we get our get some blood tests done. Mild bleeding with a normal hemoglobin, and when the patient is not looking for contraception, if they don't want contraception, we can reassure the patient and observe for some time. It is not important in mild bleeding that we give something immediately. If the patient has pain and bleeding is still, it's bothersome, worrisome for the patient, we can give them just regular NSAIDs and tranexamic acid during periods, and that should help control it. But when the patient is using tranexamic acid during a period and still complaining of bleeding, then hormonal therapy is required. That's when we call it moderate bleeding. When tranexamic acid is not controlling the bleed that's happening, then it is important that the patient requires hormonal therapy, like a combination of estrogen and progesterone oral contraceptive pills or progesterone only hormonal pill, which can help control the bleeding and regularize the cycles. Sometimes we do get patients who come with severe bleeding, with a drop in hemoglobin, who come in a shocked state. It is essential. That's when, as ER physicians, it is important that we identify that and we resuscitate the patient accordingly. We have to secure 2 large bore IV cannula, start fluid bolus, resuscitate the patient. Importance of tranexamic acid cannot be, I can't justify it enough. Tranexamic acid is the most important therapy in any case of bleeding. It will help reduce the bleeding to a very large extent. In the ER, send the bloods, get a hemoglobin quickly, see, get a normal ABG value. Our ABG teaches us a lot, because if the patient is shocked, the patient will have high lactates, will be in acidosis, will require blood, send blood for cross-matching, start massive transfusion protocol, 1 PRBC is to 1 FFP is to 1 platelet. That will help reduce the bleeding. If the patient is instable, despite your fluid resuscitation, blood is required. So start massive transfusion protocol, because the patient do come with a very significantly low hemoglobin. So it is important that as ER physicians, identifying severe menorrhagia where the patient is shocked is very essential, because menorrhagia can be a reason where the patient goes into shock and eventually metabolic acidosis. So manage the airway, breathing, and very important, manage the circulation, resuscitate your patient properly, and start blood as soon as possible. I'd like ma'am to continue.
Yes, Emma. So this is another scenario, another gynecologic emergency. A 32-year-old lady comes with a complaint of pain in the lower abdomen. She also has a foul-smelling vaginal discharge. So that is a catching point there. So what would be your diagnosis? Definitely pain with some burning in urine or a vaginal discharge definitely points us to a pelvic inflammatory disease. So PID. So such a fancy term. Dr. Sama, would you like to talk on this?
Pelvic inflammatory disease, yes, ma'am. It is infection of any part of the reproductive system, from cervicitis to salpingitis, all of it can come under PID. It is ascending, it's basically an ascending infection. But more than that, I'd like to say differential diagnosis of abdominal pain. In ER again, we do diagnose appendicitis, renal colic. This is all on our fingertips, but it can't specify enough the importance of being able to diagnose properly gynecological emergencies. PID in a patient who's sexually active with pain, bilateral tenderness, not fever, the patient can present in a state of shock. The patient, we do get a lot of stable patients, but in the ER, we see more shock patients who come in septic shock with the primary focus of infection being a pelvic inflammatory disease. It is important that we stabilize our patient, send samples, and along with blood, we are very used to collecting blood cultures and urine cultures. In pelvic inflammatory disease, it is essential that we collect a high vaginal and cervical swab before starting the antibiotics, so that we get we can diagnose it properly. Again, a transvaginal ultrasonography and antibiotics should be started immediately. The patient should be stabilized. Other causes of pain abdomen like appendicitis, surgical referral has to be given. Functional ovarian cysts, they can come with sudden onset sharp stabbing pain. It is essential that we stabilize the patient and give proper analgesia. Any patient coming to your ER not receiving analgesia in this age of time, which is just not acceptable. There's another condition called ovarian hyperstimulation syndrome. Patients who are generally, what we generally see is a patient who comes with, who has a history of infertility, who's on treatment for infertility, can go into ovarian hyperstimulation syndrome. They can come present with bloating, pelvic pain, nausea, vomiting. Such patients can come with severe pain. Severe pain, sometimes it is misdiagnosed as ovarian torsion also. So it is essential that we get an early gynec referral and get the proper ultrasonography done and can manage the pain. Non-steroidal anti-inflammatory drugs can be given if the pain is still not, if the pain still doesn't subside, then opioids have to be given.
Yes.
Renal colic is I think one of the most common causes of abdominal pain that we see in our emergency. Rectal diclofenac and early urological referral helps manage the pain pretty well. Adnexal torsion, ma'am, again, ovarian cyst, PCOS can present with intermittent colicky pain, nausea, vomiting, pyrexia. Appropriate analgesia and proper referral for the gynec, and keeping these diagnoses in mind is the most important thing, I think, as ER physicians. We tend to look at the surgical emergencies. We see them twice as common because we have more number of patients, but it is important that we keep these gynecological emergencies in mind when seeing any female case.
Yes. Yes, Dr. Sama. So as Dr. Sama has told us, pelvic inflammatory disease is usually the result of infection ascending from the endocervix, causing endometritis, salpingitis, parametritis, oophorytis. Can also cause tubo-ovarian abscess, pelvic peritonitis. That's where they present with all the bad things, shock and sepsis and all these things. So the most common organisms are Neisseria gonorrhea and Chlamydia trachomatis. So I know these are not so important, not so interesting things for you, but they are very, very common. Neisseria, this gonococci and chlamydia are very common in our settings where we get PID from these organisms. Next slide. So they present with lower abdomen pain. So typically it is bilateral pain. In PID, it's a bilateral lower abdominal pain. They also have deep dyspareunia, abnormal vaginal bleeding, including postcoital, intermenstrual, and also some menorrhagia. There can be dysmenorrhea. And we have lower abdominal tenderness, adnexal tenderness, cervical motion tenderness. So these are elicited on a pelvic examination. So diagnosis of PID and empiric antibiotic treatment should be considered and usually offered in any women under 25. So why are we all so bothered with pelvic inflammatory disease because it has some complications, and complications are infertility. So even the asymptomatic episode of PID, so the women did not have any symptoms, still the tubes can get blocked. One episode can give a tubal blockage and leading to infertility for the girl. And there's this Fitzhugh-Curtis syndrome, you find the perihepatic adhesions. So these are all the complications. That's why we are worried with PID. And we have already discussed this diagnosis. Next slide.
One second. Yes.
Okay. So once we have diagnosed, the thing is we start them on antibiotics. We have specific guidelines as to what, and so we have identified gonococci, we have identified chlamydia in that. So we give an antibiotics which cover these organisms as well as anaerobes. So we have a regimens where we can give either a cephalosporin with metronidazole combination, or the fluoroquinolones with a doxycycline and metronidazole combinations. Yes, Sama, I think we have come to the end of this session.
Yes, ma'am.
Now we request Dr. Suresh to.
Yes, ma'am. Yes, ma'am. Thank you.
Thank you.
Thank you so much.
Please switch on your cameras.
Yes.
Yeah.
Yes.
Thank you.
Thank you so much, ma'am, for the wonderful session. I think the short time we have covered it all, including the ED management as such. Once again, thank you very much. But we haven't end. Well, basically, we haven't finished. We do have some questions, interesting questions. Basically, I think you're the right person to answer it. How to approach a patient who is a victim of suspected sexual abuse in ED? Many emergency physicians, not at the senior level, junior level, they have this doubt. I think we need to clarify this, ma'am.
Yes, Dr. Suresh. So, yes, any victim with a sexual assault is definitely a, what should I say, a dilemma even for the physician who is attending. So we get scared first. So we all have our own thoughts and things about it. But as a doctor, first give her some support. So she's already went through a trauma. So we have guidelines from our government. The government of India has given a clear guidelines as to how to approach a woman with sexual assault. So we have to give her a proper psychological support. We have to take her into confidence. We have to take her consent. So there cannot be any ambiguous questions there. Give her a support that you are a doctor there and you are there to help her. Take a proper consent and ask her the history. So she might narrate her history. And the second thing is collecting the samples for pathological examination. So those things, I think only the government doctors are qualified to do those things. But when she comes up in ER and we are there, we can help them in at least preserving those samples until the proper person to take those samples to come up. And sometimes there might be trauma. So she might be in a physical trauma, bleeding somewhere. We need to support, give them the emergency care and give them prophylaxis. So there's something called as this STIs, HIV. So screening for those things. So sexual assault is something which is sudden happen. Then we also should give them this emergency contraception. So that is one thing which we have to remember when an emergency. So first thing is taking the victim into a confidence. We have to give her a confidence that she can trust us and she can take our help, give proper history, give proper samples for collection, and give her all these things, prevention of STIs and emergency contraception. You wanted to know about what slides to collect, what samples to collect and all, Dr. Suresh?
It's okay, ma'am. If it is a brief one, I think we can say, few like.
Yeah, so it's
not to miss anything. Suppose if the legal thing, suppose if we are the first attendee, later if it even lands at the government hospital. So if defense asks you, then what you did. So what we are not supposed to miss in that scenario.
The thing is, they should not bath. They should not be allowed to take a bath, not to remove the clothes also. They should keep the clothes. The clothes do contain the stains. And it's usually and go to the washroom and wash. So usually the vaginal, the garment doctor collects the hair, pubic hair for the sampling and vaginal swabs. So they do collect slides onto the slides, the samples from the vagina so that the semen stains and all are collected. So these are the very important things. And if there are any bruises on the body. So the skin, the bruises, they need to be sampled for the skin, for the victims, the assaults, what should I say, the testing and all. Those things. So better not, what should I say, give only emergency management. The samples should not be destructed.
Okay.
Evidence, basically.
I think that clear the air for this
Yeah.
question. Yeah, ma'am. Another question is how to differentiate between gynecological and another surgical causes of acute pain abdomen, especially in the females.
Yeah. So this is a, I think, yeah. So usually gynecological cause. So even there's something called as chronic pelvic pain in gynecology. So we do read a lot about chronic pelvic pain. So we have non-gynecological causes for it. So what we get to a conclusion is any pain associated during periods and during in and around menstrual period, anything which is aggravating is definitely gynecological. So the non-gynecological usually can present throughout the month, throughout the cycle, but this is acute, which you are asking, right?
Yes.
You have some other answer, Dr. Suresh?
Yeah, I think that appropriately fit into ma'am. Yes, exactly. So if it is purely related around menstruation, obviously yes, but we should be always suspicious for anything. That's what.
So ectopic pregnancy, we get much varied diagnosis, very interesting things. The women say they are having periods, but still it can be ectopic. So they say they are not sexually active, but somewhere again, the ectopic pregnancy is such a Pandora box. It comes up again and again.
Yes, ma'am. There is another question, ma'am. Management of toxic shock syndrome in ED.
Okay.
Can I take that, ma'am? I think
Yes, definitely,
yes,
Dr.
yes.
Suresh.
Basically, this is caused by the tampons which we use. I mean, generally they use it during menstruation. Like it probably involves a sepsis criteria. Most predominantly caused by Staph aureus, occasionally Streptococcus. Always, typically they present with high fever, vomiting, diarrhea, and then widespread erythematous macular rash. If this we see, then obviously we suspect toxic shock syndrome, and always we uh, while examination always look for evidence of shock. It's a toxic shock syndrome as it's there in the name itself. So perform abdominal bimanual and speculum examination with gynecologist aside, and if you have any tampon inside, please remove it with your speculum examination and then and there itself, and then send your sepsis profile, that CBP, RFT, LFT sepsis profile, your coagulation parameters, cultures, and everything, and start giving fluid resuscitation at 30 mils per kilo. There's 1 hour sepsis bundles you need to implement there. And obviously source has been removed, and then further resuscitate with broad spectrum antibiotics. And then if still critical refractory hypotension, start your inotrope support and then shift to ICU. Yeah, I think that is the answer, ma'am. If anything you can add, you can add, ma'am, for this.
See, yeah, toxic shock syndrome is very common in foreign countries, but now with the increased tampon use in our country, I think 1 odd cases might come up. So we better be ready for this management of these cases.
Yes. We have another question, ma'am, of the gynecology, but kindly help discuss management of hyperemesis gravidarum not responding to conventional antiemetics.
Okay. So we again have some guidelines and we have steps in treating hyperemesis gravidarum. So definitely yes, our regular metoclopramide and ondansetron are the first management options. If they don't respond, then we move on to even the steroids. Corticosteroids are very effective in managing in preventing hyperemesis.
Okay, ma'am.
Yeah.
I think at the end, I think role of ultrasound in emergency department. Some I think you can close this.
Role of ultrasound in ERs, I can't emphasize enough on that. Whether it's trauma, gynec emergencies, anything, the first thing I do is screen my patient with an ultrasound. That will give you an immediate diagnosis. If there's any bleed, you can find out whether if the patient is shocked, you can see if there's a bleed in per abdomen, or if you can rule out a pericardial effusion. So ultrasound, I think every ER physician, it is essential. And now with the multi-specialty hospitals and all the ERs becoming so advanced, I think all the ERs have an ultrasound machine available, if not in the emergency, in the hospital, which can be moved to the ER on call. So it is very essential that all the ER physicians know at least the basics of ultrasound, at least our EFAST, extended fast sonography in trauma, which even apart from trauma, I think we can use it in multiple places. And just a screening 2D echo, which will always clear a lot of, gives me a lot of diagnosis. You can rule out a pneumothorax, hemothorax, pericardial effusion, abdominal emergencies, free fluid in the abdomen, raises suspicion of, it can raise suspicion of any kind. There's some leak happening somewhere. So you have to find that is your cause. So that'll help draft your management plan in a much better way. So role of ultrasound is very important in the present year.
Yes, ma'am. Before closing the session, any closing comments, ma'am, from your end? I think thanks for your time.
Thank you, Dr. Suresh, for this wonderful opportunity.
The invitation and with us. Can we close the session, ma'am?
Yes, definitely, yes.
Yeah, fine. Thank you so much for the attendees. Okay, I hope this was an interesting and I think clarify all your doubts related to gynecological emergencies. And see you all once again. Thank you. Thanks so much.
Thank you. Bye.